in the mid 2000s, the American College of Surgeons published a series of reports on wellness in surgeons, and what they found was a high prevalence of what they were calling burnout, and burnout that was specifically associated with suicidal ideation. So they found that the levels of suicidal ideation in surgeons were about twice that in the average population. What they also found was that the worst rates were in vascular surgery. For whatever reason, this wasn't well publicized in the vascular surgery world. So, about 10 years ago, Dr. Coleman and I became very interested in this, and Ken Slaw, the exec director of the SBS, started a task force to look at wellness in vascular surgeons. And one of our first priorities was to see what was going on currently, because at that time, the ACS data was already about a decade old. So we didn't know if that was like a one-time thing or what exactly was going on in the 2000s that led to all this burnout. So we did the largest study on vascular surgeons. We had about 1,000 vascular surgeons who we assessed for burnout, and commonly held theories about what would predict burnout in these vascular surgeons. And what we found that the levels of burnout were just as high as they were in the mid 2000s from the American College of Surgery report, and that the suicidal ideation was still very high in vascular surgeons, the rate of suicidal ideation. We also found some triggering factors. A recent malpractice suit was a big one, unfairness in compensation, and most of them were workplace environment factors. So it wasn't the usual alcoholism or drug abuse or any of these other things that were contributing to burnout. It wasn't even the work hours that we do, because we do work a lot, but it was the environmental factors that were driving burnout in vascular surgeons. And so these, interestingly, could all be modified, or for the most part could be modified. So we set out to kind of publicize this. And I think she and I have done probably hundreds of talks on burnout. We go to different hospital institutions, talk to a lot of places at that point in time, started wellness officers to kind of look after this. And it's always very suspicious when, corporate hospital entities put money into anything, and they generally don't do it unless they're preventing money loss. And what was known at the corporate side is that this thing we're calling burnout was real, was causing early retirement, and that early retirement cost the healthcare system millions of dollars, because it takes about $1.5 million to recruit and replace a surgeon. So by preserving their workforce, they felt that it was worth the investment into wellness. Now, unfortunately, the data on what affected burnout at that time wasn't too good. So a lot of the early wellness efforts by the healthcare systems were put into things like mindfulness or yoga, or office parties, or things like that, birthday celebrations, things that we know now do not affect burnout one bit. It's, like I said, it's mostly an environmental issue. It's the things that prevent you from doing your job. So vascular surgeons don't get burned out from doing vascular surgery. They get burned out from doing all the things that are unrelated to vascular surgery. Charting, onerous tasks, billing, pre-authorization, all the things that the hospital may see as your job, but which we don't see as our job, or is not what we derive pleasure from. So the higher percentage of what a common exercise I do with people is they close your eyes. Now imagine your day. Imagine what you want to do, and then imagine what you actually do, and how much percent of your time is spent doing what you want to do versus what you have to do. And if that percent of time doing the things that are unrelated to what bring you joy in the profession is higher than 40%, you're in trouble. If it's higher than 50%, you're already burned out. And so that's that allocation of time to the tasks that have nothing to do with being a vascular surgeon are probably the biggest, most critical driver of burnout. And this information is getting to corporate entities, and they understand these things better now. So we're better, I think, at treating or preventing burnout, but it hasn't really been reflected yet in the workforce. So the Wellness Task Force, which became the Wellness Committee for the SVS, was really focused on surgeons in practice. But especially Dr. Coleman was always concerned about the trainees and what was going on with them, because we figured it might be similar, but we didn't know for sure because training is a finite period of time. So sometimes you don't get burned out by things as much if you don't see it as this is what I'm going to be doing for the rest of my life. So the second trial was really started in general surgery, and we developed the second trial arm for vascular surgery. And again, this was really Dr. Coleman's idea and initiative, and then I kind of came on later as a representative from the vascular surgery board. And so the second trial looks at wellness in vascular surgery, mostly integrated residents. And what we found was that the levels of burnout were about 40%, or very similar to what we were seeing in attendings. And again, it makes sense because they're working in the same environment. We found some things that were very unfortunate. It seems to disproportionately affect women in vascular surgery, and that's one of our first findings. Another important thing, again, it all ties back to this being an environmental health risk. And so the level in vascular surgery programs was not stable. Some programs have a lot of burnout, some programs had less burnout. And that's good. That means it's modifiable. That means there are best practices that you can achieve to have lower burnout. So we started giving the programs their reports every year. The vascular residents will take a survey once a year, and then we give the report back to the programs, and then they can try to modify. We also send them tips and tricks and webinars and all kinds of things. But, again, it's a local process, an environmental. So sometimes it's hard generically to tell a program what to do to improve their wellness because we don't know other than large scale factors. Certainly duty hour violations was a big one, but abuse, we found that abuse is pretty rampant, and it's not the abuse that you might think. It's not always the attending who is abusive to the resident, but sometimes it could be patients' families, patients themselves, nurses. There's all kinds of factors that contribute to the abuse levels that the residents go through. So just learning about that and how to prevent that, I think was very helpful. And then trying to cut down on the gender disparity that we're seeing too, where the women seem to be disproportionately affected. And then initiatives like pregnancy leave that the board has actually backed, more lactation stations, just helping people have a regular life. When I was a resident, you were expected not to have any kind of life. You weren't. I think I went back to work famously the day after my wedding. Like there was no honeymoon right then. I just went back to work. The thought of having a child was inconceivable during my training. But now with duty hours, it's more feasible to have a regular life, and they do have regular lives. And so we have to adapt training to incorporate their regular life, or they will burn out. So the attrition rates are very low. That paper is still in publication, but we just presented it here at SVS. So attrition rates in integrated vascular are actually very, very low, and significantly lower than what we see in the integrated cardiac programs. And I think one of the reasons is, in general, vascular surgery programs do very well. They take care of the residents, and most of them are not malignant. And so the vascular surgery residents enjoy vascular surgery, and they enjoy their programs. This was a concern, attrition, specifically to see if there was some kind of discordance for gender or race or ethnicity. And there don't seem to be. Gender, we can say almost assuredly, that does not seem to be affected by or predictive of attrition. And race and ethnicity, the numbers are so small, it's hard to tell for sure, but it doesn't appear to be a factor in attrition. So yes, the numbers are low. And again, vascular surgeons do this because they want to do vascular surgery. So I think even if you get burned out during training, most still push on to finish. But it does affect, we do see that it affects V-site scores, for instance, which is a marker of learning, right? So if they're burnt out, they're not learning as well. They're not getting the skills that we want them to get. So it's still very important to prevent burnout, even if it's not causing widespread attrition. I think for vascular surgery, at least as it pertains to training, we created a new paradigm which debuted in 2007. And it continues to grow to this day. We had 110 positions in the last match and started from 3 in 2007. So we've exponentially grown it. So I think it would be very naive of us to think that we just got it right at the first attempt. So I participated with the ACGME a year or so ago to renew our program requirements because we need to constantly innovate, constantly improve the way we train people. And one of that might be competency-based paradigm. So right now, you train in integrated vascular surgery for 5 years, set in stone. No matter how good or bad you are, it's 5 years. And a competency-based paradigm where you finish when you're ready might be better and might actually help with some of the burnout issue because the time-based constraints can put a lot of pressure on people. Now, there are alternatives or negatives to a competency base because if you're starting somebody, you don't know when they're finished, the funding gets a little fuzzy. Maybe you have a whole bunch of residents now going 7 years, so you have more residents than you started with. So how do you allocate those cases? So there are concerns with that as well. But I think that, if we stay flexible with our training paradigm, I think we could do a lot to prevent burnout. And when the residents learn good, healthy coping skills, I think in the residency program, they're better at selecting the right jobs. And so they learn that what can cause burnout in the environment and how to look for those things in the job. Not everything's about money. So if going to get paid $1 million to go work for some corporate entity in an OBL and churn out cases all day, you might make a lot of money, but the elements of burnout are there already. You can see it coming from a mile away. That's not really why any of us went into vascular surgery. There's easier ways to make money. So we like to be compensated well, and that's a marker of wellness, is if you feel you're getting fairly compensated. But that pursuit in itself can also drive you to burnout.